Welcome to another episode of the Back to School Shootings podcast. My name is David Reedman. I'm the creator of the K through 12 school shooting database. On this podcast, over the first 50 episodes, I have had lots of social science doctors, doctors of economics, doctors of psychiatry, but there have also been a couple of physician doctors. And today is one of those physician doctors, Dr. Sarabeth Spitzer. And we are going to talk today because, in addition to providing medical care, when she was a med student, she founded a national advocacy organization, which is called SAFE, Scrubs Addressing the Firearm Epidemic. So I think it's important that we have perspectives on both gun violence prevention and the real world implications of gun violence and gun violence involving children. So, Sarah Beth, thank you so much for joining the show today.
Thank you so much for having me. We're thrilled to be here.
And even though the audience can't see us, it looks like you're in a call room or something. I see a white coat hanging
Oh,
out
I'm in
behind
a
you.
very
Where are you working right now?
a
What phase of
glamorous
your
call
career are
room.
you?
I am currently a general surgery resident. I'm at Brigham and Women's Hospital right now. I hope most people don't know the standard pathway for physicians because it takes way too long. So it goes medical school at the beginning, residency in the middle, fellowship towards the end, and then attendinghood is kind of the dream goal that in theory one day I'll get to, people claim. So I'm in the middle of my 7-year general surgery residency at Brigham and Women's Hospital.
And right now, you are eagerly waiting a trauma surgery fellowship match, correct?
That's correct. So I will be a trauma fellow starting next year.
And if you could just kind of talk the audience through, if they're not familiar, what is the difference between, say, an emergency room doctor versus a general surgery resident versus then your trauma surgery fellow?
It's a great question. I get it all the time. My parents still don't understand. So, a emergency medicine doctor is stationed within the emergency department at all times, and they see everything that comes into an emergency department, whether that is a allergy, a rash, a stroke. You know, there are a huge host of things that emergency medicine doctors respond to, and they're kind of our first line entry into the hospital. A trauma surgery attending and fellow is focused only on traumatic injuries that come into the emergency department. So, anyone that is there because they had a fall or a stabbing or a gunshot wound, the trauma surgery team will be involved with, in part because there's a chance that you have to go to the operating room to fix that. And that's really the main role of a trauma surgeon, is the one who takes someone from the emergency department to the OR to then do what needs to be done.
And we'll get into this more in a few minutes, but obviously there's an enormous amount of training that goes into being that trauma surgery fellow. Why is it so important for a gunshot wound victim to end up in your trauma bay as quickly as possible? And why are all of these other people, from a first responder with a stop the bleed kit to your EMS unit to your emergency room physician, why are all of those people um, not going to be able to kind of fully treat the gunshot wound in the same way that you can in the trauma bay?
It's a great question. So, depending on where a gunshot wound hits, there is a high likelihood that you need an operation to fix it because often a bullet wound will leave a trail of holes in things that should not have holes. And depending on where those holes are, they can kill you at varying speeds. So, the thing that we worry about first as the number one quickest reason that you could be killed from a gunshot wound is bleeding. It's why the campaigns, in order to try to teach civilians how to hold pressure on bleeding wounds, are so important because bleeding is the quickest way. The other things that are still extremely dangerous are holes in your intestines, holes in other organs that are in your abdomen or your chest. Those can cause kind of greater problems on the order of maybe an hour or so rather than minutes, like really bad infections. And so those you need to close the holes. You need to figure out what has been injured and get it out and kind of physically sew it up. So an EMS team is kind of absolutely incredible at getting these patients to the trauma bay where they need to be. The goal is within as quick a time frame as they can handle. There's something called the golden hour in trauma surgery, where if you can get someone to an operating room and kind of operating within that hour, there is a thought that there's a much higher survival rate. So all of those teams work together really quickly, really to get you to the operating room as soon as you can.
And even in military medicine, that golden hour has been even truncated down to the platinum 10 minutes. That if there's a way to get somebody with a gunshot wound or major trauma into a surgical setting in 10 minutes, you have a dramatically higher uh, rate of success there.
It without a doubt, it is not a, hour, but it's only been 30 minutes, so let's dilly-dally. The quicker you can get there, the better. So everyone is absolutely, mobilized just to get anyone that needs an operating room into the OR as quickly as you can.
And just to kind of expand on that a little more, so lots of schools are now equipped with a stop the bleed kit, and that might have an occlusive dressing, some sort of trauma dressing with different kind of elements to cause clotting, maybe a tourniquet, which it's important that only can go on an extremity, but most
Correct.
often
Mhm.
people are shot in the torso because it's the largest part of your body. If you're in a classroom, the worst happens, a student ends up getting shot, you've got the stop the bleed kit, but the school's on lockdown. I think it's important for a teacher or a school official to know, just because you slap that stop the bleed kit on somebody, they still need to get to a hospital very, very quickly.
Absolutely. The most important thing you can do is get people to a facility where they can be treated with, expeditious medical care of all sorts. It's obviously extremely challenging. You have to be cognizant of what else is going on around you. Are you in risk, of getting an injury? Are there more people that are at risk? It's an impossible situation to be in, but certainly that stop the bleed kit is just the first step. And it really is the most important thing to get people into the hospital as soon as possible.
Yeah, and that's where the military really changed the paradigm in the past 10 years or so, because a lot of what we know about emergency medicine and trauma care had first come out of the Vietnam War, and that's where we came up with the ideas around medevacs and having a field surgical center and quicker care. But then there were all these new lessons from Iraq and Afghanistan, and seeing that actually, you know, even if you have a hot zone where there's still bullets being fired, if you can get somebody transported out of that hot zone before the combat is over, there's a much greater chance of saving them. And I think that needs to be in the mind of every teacher or school official or police officer who's responding to a shooting on campus. There's been, training since Columbine that you find the shooter above all else. But in reality, if there's a bleeding victim and you want to save a life, getting that bleeding victim to a hospital as quickly as possible is going to have a very, very profound impact on the ability to save that person.
Absolutely.
And then just since you're in the midst of your residency and you know so much about surgery at this point, what's the difference between a child being shot and an adult being shot in terms of how quickly something can go south and whether there's kind of more or less need to get them to a facility quickly?
It's a very interesting question, actually. So, I would say, in terms of a need for speed, they are both absolutely as fast as you can. I would not say that one can take any minutes extra than the other. What is interesting is that kids typically, and I would put kind of young, healthy adolescents in the same category too, in their teens, early 20s, you have a physiologic reserve, is the way that we describe it. But essentially, your bodies are able to handle more of an insult for a little bit longer without showing signs of that insult. So, someone can come in shot looking better than you might expect, but then they will very quickly get extremely sick. So your body is much better at compensating, and then will kind of fall off a cliff at some point. And once that happens, it's very difficult to kind of make a resuscitation successful. So younger kids, adolescents can look like they're doing a little better and kind of fool you at the beginning, whereas older individuals have a little bit less of a reserve. So they will more quickly show how gravely ill they are.
And that's another important one for police officers around a school or for any school officials. the most common scenario for a shooting on campus is a fight that escalates. And it's usually at lunchtime or dismissal, and it's around the outside or front of the building or the parking lot. And when a student is shot, they most often run back to the school for help. So you might see somebody who's run across the parking lot, run down a hallway, banged on the office door for help. They might seem like they're okay, but they're able to compensate right now, but they might end up crashing really quickly. So you need to realize that this teen or child who seems okay may go south very, very quickly.
Absolutely. And I would also add that one of the physiologic responses when you're in shock, which is when you have a loss of blood or you're septic from a hole in your intestine, and young folks get this very notably, is that you can become agitated and angry appearing. And there is um, occasionally a bias in the patients that we see when they are brought into the hospital. They're thrashing, they're screaming, they're angry, they're inconsolable, and they're being held down. There is a kind of security concern initially, when really it's not a security concern. It's a physiologic reaction that something deep down is going very wrong, and the flailing, the kind of aggressive behavior is actually a symptom more so than something that needs to be stopped. And so, even when you see folks that are screaming, yelling, whatever it is, just try to remember that it's not that they're being aggressive. It's an actual physiologic reaction that they are managing, and it's part of that symptom of being really gravely ill. And so, those are the people that actually need to get to the hospital even faster.
And I mean, that's really important for a teacher or a school administrator. If you have a student who's been shot in a classroom and all of a sudden that student is becoming extremely agitated, you might think, wait, we need police to get in here and figure this out before we're providing kind of any assistance. But that's somebody who's really gravely injured.
Very sick. Get them to the hospital. I would say if someone has been shot, there is no time ever when it would be appropriate to wait for a police escort. It is always the most important thing to get that patient to a hospital.
So we dove right into the meat of the discussion because I mean, seeing you there in the hospital with the white coats, like we gotta hit these main points. But let's back up for a minute because med school is no joke. It's a 6 or 7 day a week, 12-hour plus type of activity. Like it is a horrible, horrible period in life from everybody I know that's gone through it. But in the midst of that, you started SAFE, Scrubs Addressing the Firearm Epidemic. First, why did you even have time to think of that during med school? And what was the impetus for this?
Yes, I mean, I'll give Stanford a huge shout out. I was a medical student at Stanford, and it was, very challenging, but it was an amazing institution. And so I started research on firearm violence my first year of medical school. I have always been interested in trauma. This has always been an issue that's been pertinent to kind of my interests. And um, during my years of medical school, which were 2015 to 19, there were massive numbers of shootings, and one of those was the Parkland school shooting. And when I was at Stanford, there was a huge coalition of professors of medicine that essentially were saying, this is just one too many. We have to try something. And if you can believe it, a medical student actually has more time than an attending. So I was a little more flexible and able to really dedicate a lot of time to coming up with the answer to that question of, what can we do from the medical side to try and reduce shootings? That was really our goal. And throughout this amazing group of people, we came up with a mission, which was to ensure that healthcare providers had the skills and the knowledge that's evidence based to be able to advise patients, communities, and legislators on firearm ownership in order to reduce injuries and death. And one of the big things that prompted this mission was that Stanford, which was, again, absolutely amazing medical school. When I was there up until my time, there was no education from a medical student perspective on guns. You learn about everything under the sun. You learn about how to have challenging conversations about sexual infections, and you learn how to ask people about very personal information all the time. But there was no information about gun safety, how to have conversations with your patients about such an important issue. And so that was really the start of this organization, was to try and create a group that could help teach medical students across the country how to have these conversations, what information they needed, so that they could then grow into the physicians that staff the emergency departments around the country and know what to do when faced with these circumstances as physicians.
And is your recommendation that every single time you're having an interaction with a patient, that should be a time when you have a discussion about gun safety?
I would say yes. I would say if you are lucky enough to have the time to sit down with a patient and talk about their medical history, their risk factors, we ask every patient, how much alcohol do you drink? How long have you smoked? How much do you smoke? All of those are routine questions so that we can get a baseline understanding of your health. And I think a third category to go along with that, without a doubt, should be, do you have firearms in your home? If so, how are they stored? Who has access to those? Do you have children in your home? All of these are questions that are highly relevant to not only the patient's life, but the individuals in the patient's family that might have access to those guns.
And let's just walk through how one of those discussions would go. So imagine I'm your patient and you're doing my health history. What's the progression of that discussion about firearm safety?
So I think it totally depends on the patient, but I would do it in just that way. So there's you ask, why is someone here right now today? You kind of go through all of that information. And then there's a kind of period after that where you get a sense of their medical history. Do you take any medications at home? Do you have any allergies? And then usually after that, there's something that we call the social history. And I would say just those things. Are you sexually active? With whom are you at risk of any infections in that kind of areas, why I would be asking those questions, followed by how much do you drink? How much do you smoke? Do you have a weapon at home? And depending on the patient, it goes in a very different
So
direction.
let's assume I say, yeah, yes, I have multiple firearms in my home.
I would say, all right, how do you store those weapons?
I keep them accessible in case somebody breaks into my house in the night.
Okay, where do you typically keep those to make them accessible?
There's one in every room of my house.
And are they at ground level? Are they in anything that's closed or locked?
No, they're available in case I need them immediately.
And who is in your house other than you?
I have a daycare that I run from my house. So I have many small children that are difficult to supervise.
I would be having a lot of anxiety at this particular moment. And that's when I would say, well, there are lots of pieces of evidence that show that all of those children and you are at much higher risk of injury and death from a firearm if they are out and available. And one question I would ask is, are those weapons loaded? If they are loaded, are they on their safety? All of these different safety mechanisms. But, obviously, there is abundant evidence to show that kids around weapons is dangerous. Without a doubt, kids are unbelievable at getting into everything that they shouldn't. Anyone that's been around a 2-year-old knows that they'll find the one sharp thing in the room that hasn't been baby proofed within 30 seconds of getting there. And guns are no different. And it's absolutely tragic, the number of kids that lose their lives or have their lives very significantly impacted because they get access to a weapon that's out, loaded. They think it's a toy. They don't know what it is. They're so young that they are just pressing and clicking buttons. And suddenly that patient's life is forever different. And so, keeping those weapons in locked areas, unloaded. Ideally, you want the ammunition and the weapon itself locked in different containers separately. There are frequently questions that I get, just as you were kind of getting at, where you say, well, I'm concerned about my safety. It's not helpful to me if my weapon is not very quickly and easily accessible. Then I would say there are very specialized lock boxes that you can get where they are extremely quick to open. Some of them just use a fingerprint. It's very quick. And all of those methods are proven to reduce risk of injury when a weapon is in the house. And importantly, it's also to the individual. We talk frequently, as about the devastating incidents of kids being shot, mass shootings in schools. Suicide is actually the number one cause of death from guns, and one of the reasons is that you cannot take it back when you shoot yourself with a gun. That is something that is, unfortunately for people that are in that circumstance, a highly morbid situation. And the reality with suicide is that it's actually been shown to be quite circumstantial, which means that someone comes home, they've been drinking, they have a fleeting moment of despair. One person that kind of has nothing by their bedside goes to bed and wakes up with a bad hangover. Someone that sees a loaded gun right there can use it and take advantage of it. And it's one of the hypotheses for why men have a higher rate of suicide than women, because more men have loaded weapons around and available, whereas women have more often tried to use things like medication to commit suicide, and it's less morbid, meaning that most people that try to use medications to commit suicide get the opportunity to wake up and say, I did not mean to do that. That was a one-time dark moment, and I'm gonna come out of it. And guns are just different.
Yeah, I mean, kind of unpacking that danger, the perceived danger, which is used in a lot of gun industry advertising around, you need to be the protector of your family. There's going to be this evil person trying to get into your home. Armed home invasions are in the single digits in most entire jurisdictions. Like, it is extremely rare to have an armed home invasion unless you're actively selling narcotics or you're involved in illegal activity where there are other people kind of in that heavily armed world that would want to rob you or take you down or whatever. A normal person is almost never the victim of an armed home invasion. But looking at those types of gun deaths and shooting injuries, which there are, at least 10x as many injuries as there are gun deaths, accidents, very high rate in the home. When you look into the child gun death data, by individual age, 4 years old is the most common age to die of an accidental gun death at home. And as you were saying, that's just kind of the age where the kid is tall enough to reach or climb into just
Mm.
any part of the house. They're smart enough and have enough dexterity to load and manipulate and, open a box or load a gun or accidentally shoot, themselves or their siblings. After that, suicides, especially men between 30 and 60, is this rising demographic in firearm suicides. But the biggest danger, really, to the family is that if there's a loaded firearm around, domestic violence turns into shootings, and just fights between family members and neighbors turn into shootings because somebody is making a highly emotional, highly impulsive decision. There's a gun right there, and that argument with my neighbor about why his dog keeps going on my yard turns into a shooting. Or that argument when you're drunk with a spouse, all of a sudden somebody reaches into the drawer, pulls out a gun, and now you have a homicide. So very, very low risk of ever shooting some sort of armed intruder. Very real risk of either shooting one of your loved ones or them killing themselves or just an accident happening.
Yep, absolutely. And I would say that for anyone who owns a weapon, I would recommend having a significant training kind of course to go along with that weapon. But especially for those that are buying a weapon with the intent of protecting themselves in their home, it is critical that you get training in actually the kind of skill of using a firearm, because it is not as simple as if you have a weapon. you're therefore safe, you need to learn how to aim that weapon and kind of control the use of that weapon in a very stressful circumstance. And it's actually extremely difficult. This is not something that the average person can pick up and use successfully without hard risk. So
And so we talked about the acute care and the need for, surgical intervention when somebody has a gunshot. You deal with all kinds of traumas. You have falls and fights and car accidents and motorcycle accidents and construction equipment, everything you can imagine. When somebody's shot, that can happen so quickly. It can just be a little hole in their body. You treat that in the next couple hours. What are kind of the long-term impacts that you see from a lot of these shooting injuries, and how are they kind of different from a lot of the blunt force trauma that, would just kind of
yeah.
happens in accidents?
Yeah, it's a great question. So, blunt force trauma, for the most part, the research that we have right now suggests that we can get away usually with operating actually a little bit less. So, blunt force trauma can be very severe. I do not mean in any way to downplay it, but what it does give us the opportunity to do is sometimes watch patients a little bit, not rush them to the emergency or the OR from the emergency department, and kind of see how they do. A gunshot wound is very rarely that case. You are almost always taking someone to the operating room very quickly. And because of the kind of potent impacts that a bullet can have on the body, there are just an absolutely impossible to describe number of horrible ways that you can kind of leave people living for the rest of their lives. So there are folks that end up with colostomy bags where, a young guy gets shot, their colon is no longer viable. And so for the rest of their life, they have a colostomy bag. That's, on the most part, not a huge deal to me or someone else that takes care of these injuries. You're like, well, it's fairly lucky. There are people that are paralyzed, from their neck down. They can no longer use any of their limbs. They have a hard time communicating. Some people can't eat anymore. They can't swallow properly. They end up with a breathing tube that is kind of responsible for helping them breathe for however long they can. And so it can really severely change the course of these folks' lives. And as you mentioned, they're often young. So these are young people that are otherwise used to doing things for themselves, capable, working. And one of the huge issues that we see is that after a injury of that kind, you can no longer get a job, you can't support yourself, you become a dependent on someone else, who is then responsible for taking care of your medical needs, which can be enormous. So it's a really burdensome situation to both the patients, their loved ones, society as a whole. It's extremely hard.
And the final question that I want to ask you, because I think this is really practical for parents or teachers, anybody who's thinking about making some kind of nominal price purchases for their school district. If you're a parents group and you're trying to fund, some sort of proactive measure for the schools, what would you recommend in a first aid kit that either, let's start with, a parent has at home? What are kind of the essentials to have there? And then if you're a teacher in the classroom, is there anything else that you would want to have in that kind of first aid kit?
Um, going back to our first conversation, I would say the most important thing to have is a cell phone because you have got to just get help on the way. That is the number one most important thing. The second thing I would say is a understanding of manual pressure, and something to help with that. That could be an ace bandage. It could be, a bed sheet. It could be really anything that you have on hand. But I think that the sad reality is that a first aid kit when it comes to a gunshot wound is just not going to cut it. And that is the heartbreak of gunshot wounds. It's why they are so mortal. It is a really hard problem to fix. This is not the sort of thing that you can kind of get by with a little bit of bacitracin. You've got to get to an emergency department as soon as you can.
And if anybody listening is either a physician who wants to get involved with SAFE, scrubs addressing the the firearm epidemic or somebody that just wants to support your organization, what can they do? How can they get involved? How can they support you?
That's a great question. So we have a safe website, Scrubs Addressing the Firearm Epidemic. If you just Google it, you can find it, and there's a donation page right there. And then there are a couple kind of three main goals that we're working on right now. We talked about the firearm injury education curriculum. That's kind of a mainstay of the organization, which is the piece that works on improving medical education to chapters across the country. So I would say if someone is in a particular region and they have a medical school or a hospital that they have used and they feel are devoted to, they can find the safe chapter and see if there's a chapter associated with that hospital. um, the other thing that we are working on is a kind of policy pillar to look at secure storage. As we talked about, that's a huge kind of saver in terms of making sure that escalation slows down, and it really does have an impact in terms of risk. And so, getting access to gun locks and different storage facilities that we have nearby is one way that people could donate. And then the final way is a secure storage campaign that we're piloting right now at four different medical schools across the country. And we're really trying to actually take some of these secure storage methods and bring them into kind of the clinical setting. So we're looking for $7,500 for each of those four groups. So that's another way. But if you go onto our website, which you can kind of find pretty easily, then you can kind of come up with a way to donate.
Well, I know you're busy there because you're clearly working and providing services at the hospital today. So I'm not going to take up any more of your time. So the guest today, Dr. Sarabeth Spitzer, she is a general surgery resident, soon to be trauma surgery fellow. Once we hear the match location, put an announcement up and make sure everybody knows where they can find you next. But I want to thank you so much for this information, for everything that you're doing for this advocacy. And hopefully, this can make a difference on educating some people about the real risks that they're facing.
Thank you so much. And, I'll just make one more plug for SAFE. It's standsafe.org in case anyone is so inclined.
Okay, I'll make sure that there's a link to your social pages as well as that website in the show notes. So thank you and good luck on the rest of your shift.
Thank you so much.